And one other thing you need to know about advanced directives is that our ability as physicians and family in study after study have shown that our ability to predict what a patient's wish might be without extensive prior guidance is really not very good. So that isn't something that you can intuit. You really have to have the conversations and to put it into these format, into the advanced directive. As we'll talk later, both a written directive and the dialogue about it are necessary for the patient's preferences to be implemented effectively. Number 7. Some situations that you may wish to consider your treatment preferences are on this slide. A stroke that leaves you unable to swallow, a massive stroke or head injury from which you're unlikely to regain consciousness, progressive debilitating disease such as Alzheimer's or advanced Parkinson's disease, end-stage cardiovascular disease such as a condition requiring a pacemaker or a defibrillator, refractory infections for which antibiotics are unlikely to be successful, and then the obvious one that most people think about is the late-stage cancer. In the next section of the talk, I'd like to talk about the factors that you might consider in determining the types of treatment that you would wish to consider or wish to avoid in these kind of situations. Any questions at this point before I go into the next section? Okay. This would be slide 8. From our work, our practice focuses on the frail, elderly, and the gravely ill. From our work, we've identified several major considerations that form the basis for patients' choices in the context of these life or major illnesses. First, the obvious one is you have to consider what the illness is, and its prognosis and its course, not only with treatment, but what happens without treatment. Obviously, the physician is your best source of that kind of information. And it's a lot of information, so it's often needed to be gone over multiple times with details and information having time to sink in and to be processed. And so those interactions usually are over a period of time, multiple visits or multiple conversations about it. This is something that we've learned in our palliative medicine practice, is that there used to be the gathering of the family and the sit down for the discussion, lots of information being exchanged, lots of good communication. But studies have shown that the one time only sit down with the family and patient to discuss the prognosis just doesn't cut it. Too much of it is lost. Too much of it is never absorbed. Too much of it is never processed. So the model that's shifted from the big family meeting and the big decision with the docs is still there, but you need follow-up, multiple meetings to make sure this information sinks in and is incorporated into that person's decision-making. So you need to understand the illness that you're dealing with. The second is the nature of the intervention itself. Typically you want to think, well, what's the intervention? How aggressive or invasive is the intervention, and over what period of time? A one-time injection is very different than a 3 times a week coming to the office or coming to the outpatient for an infusion for the next 12 weeks. That's very different. So you need to consider what the intervention is and its particular burdens, both in terms of side effects and then how to get it done. I had a patient earlier today that we were reviewing from our palliative medicine team. They were considering hospice, and the patient had lung cancer that had spread to bone and had significant pain from this. And the patient also had underlying rheumatoid arthritis. The plan originally was to have her come back and forth for 12 courses of radiation to treat that pain. Well, as a result of our palliative medicine consultation and intervention, we talked with the radiation physician and got that reduced to a larger but less frequent administration of the radiation, because it was so hard to imagine this patient coming back and forth 12 times over a period of several weeks. So it does make a difference to consider what the burdens are of the intervention. Third, patients need to consider the risk and benefit of the information in the context of the patient's underlying illnesses. The benefits are what drives you to consider doing these, but not every benefit accrues to every patient. And so you have to individualize what your likelihood is given your particular set of illnesses and what the extent of the disease is, as to whether the risk and the benefits, the burdens and the benefits of the intervention match up for you that makes it worth doing. Obviously, benefits that are less than the potential burdens or the side effects don't net you a gain, so it might influence your decision. The impact of the treatment, this is another consideration on cognition, is also a major concern for families and patients. And I, as a hospice and a palliative medicine doc, as a geriatrician as well, consider that very carefully when I'm talking about medications for the use of pain control. Because I know that medications for pain often impact the cognition. And that may be a negative, that people would wish to forego that particular medication in order to preserve their cognition. That seems like counter to what you'd hear coming out of the hospice doc's mouth, but we do. We want to consider every medication, every intervention in that light. What are the risks and the benefits of this intervention? And if it doesn't seem to fit for you because the benefits don't seem to outweigh the risks, well, then it's probably something that you should either seek to avoid or not do. 9. Fourth, patients and families consider the impact of treatment on the patient's quality of life. Loss of control and independence is a huge concern. Some patients describe some therapies as, quote, worse than death. I've had a number of patients describe that for, and forgive me if there are any patients who are currently receiving hemodialysis, but sometimes patients have described that as a condition and a treatment that's worse than death. In fact, this is really true, I had a conversation this morning with a patient of mine whose husband died of end-stage kidney disease, and he was on dialysis for 5 years. Her kidneys are failing, and she said, I know what that's all about. I don't want that. And so she, for herself, was deciding that she